when we do a AP radiograph of the pelvis, we pass the radiation. The radiation starts, the X-ray starts coming from anteriorly, goes posteriorly to the cassette that is kept in the posterior aspect. Now, the first thing that we have to understand is how the positioning that we do in an AP radiograph of the pelvis. Now, as the centering is usually done at the midpoint, now what will happen is the rays that are coming to the hip joint are the divergent rays. So to compensate this, we will do the internal rotation of the limbs such that the oblique rays are compensated by the internal rotation that we do. Normally when we do internal rotation, we won't see the lesser trochanter is not prominently seen but not visible. But when we do an internal rotation in this weave, in the AP radiograph of the hip, because of the divergent rays, we can still see some part of the trochanter, the lesser trochanter, and also along with the internal rotation, we keep both the hips slightly in abducted position, and this is how we position the patient. Now the centering is done by uh, placing the center of the beam, the collimated beam, at the upper border of the pubic symphysis in the midline, or at the midpoint between two anterior superior iliac spines, either the midpoint between the two anterior superior iliac spine or at the pubic symphysis. Now the pubic symphysis is used to image the pelvis. The centering is done at the pubic symphysis to image the pelvis, and the midpoint of the two anterior superior iliac spine is used when we do the imaging of the proximal femur. And whenever the patient is lying, the patient has to lie such a way that the patient's sagittal plane is perpendicular to the cassette. The cassette should be perpendicular to the patient's sagittal plane, and this we maintain by maintaining the anterior superior iliac spine from equidistance from the cassette on either side of the patient. After the positioning and the centering, we need to know where to keep the cassette. Now the cassette should be kept at least 5 centimeter above the iliac crest. It should be kept at least 5 centimeter above the iliac crest so that it will cover completely the pelvis. So once we do all this, we get an image like this. Now once we get an image like this, the first thing we have to see is that is there any rotation. Now to check the rotation, you have to compare two iliac crests, and if they are equal in size, then that is one thing that suggests that there is no rotation. Also look at the obturator foramen. If they are of equal size and if they are of same shape, then there is no rotation. Once we see the rotation, then we have to see for the exposure. Now exposure, when we say there is no good exposure, the upper part of the pelvis won't be clearly seen because of the overlapping, the shadows from the abdomen. And once we see the exposure, the rotation, next we have to see how the Shenton's line is. So this is the Shenton's line, which goes along the medial border of the neck of the femur, along the inferior border of the pubic rami. Now the Shenton's line will be clearly seen in a normal AP radiograph of the pelvis. This is an example of an AP radiograph with an obvious fracture in the superior and inferior pubic rami, and if you see that there is a break in the Shenton's line. So this is how the AP radiograph helps us to detect the fracture. This is one more radiograph, which again we can see that this side the Shenton's line is so smooth, this side the Shenton's line becomes very pointed, it is not curved like before. And also at that level we can see some radiodense line here. It's nothing but the fracture of the neck of the femur or the subcapital fracture. This is one more example of the dislocation of the hip joint. Again we can see that there is break in the Shenton's line.